Abnormal labor. The three things for normal labor is that is passenger, pelvis, and push. Abnormal labor are due to push, that is abnormal uterine contraction. The second factor is the passenger, that is occipito-posterior position, malpresentation or cephalopelvic disproportion. And a third factor for abnormal labor is pelvis, whether it is contracted pelvis, android, anthropoid or platyploid pelvis. So, abnormal uterine action, there are two types, that is hypoactive uterus or hyperactive. Hypoactive, that is a decrease in uterine action, decrease in number of contractions or strength, that is known as slow labor. Whereas in hyperactive uterus, there increase in uterine action. There are three types of contraction, that is coordinated, also called precipitate labor, incoordinated, slow labor. Tetanic is slow labor, that is basal tone is less than 20. So tetanic also known as slow labor. So first of all, we are talking about the hypoactive contractions and excessive uterine contraction. In hypotonic contraction, either the number of contraction is less or the strength of contraction is less. That leads to slow progress of labor. Dilation in active phase less than 1 centimeter per hour. Management for this is augmentation of labor. In that, we do artificial rupture of membrane, due to which release of prostaglandin E2. If still contractions are hypotonic after 30 minutes, then we have to give the oxytocin to the patient. Now, the findings in partograph: fetal heart rate is normal, molding is absent, progress lying right of alert line, slow progress of labor, and that is known as hypotonic contraction. First, we have to do artificial rupture of membrane. If still contraction hypotonic, then after 30 minutes we have to give the oxytonic. By giving the oxytocin, strength and duration of uterine contractions are improved. Then single vaginal delivery we can do. Now, excessive uterine contraction terms are tachysystole. Tachysystole means more than 5 contractions per 10 minutes. Second one is hyperstimulation, that's tachysystole plus fetal distress. And third one is tetanic contraction. In tetanic contraction, single contraction lasting for more than 3 minutes. Main risk factors for abnormal uterine contractions, we have to remember like 4 P's: primigravida, malpresentation, abnormal pelvis or cephalopelvic disproportion. Deflexed head, injurious use of analgesic and oxytocins leads to hypotonic uterine contractions. Now, second, having constriction ring, or also known as Schroeder ring, and precipitate labor. Constriction ring or Schroeder ring, excessive uterine contractions. Coordinate uterine contraction, precipitate labor. Incoordinated uterine contraction, spasm of uterus. That ineffective contraction that leads to spasm of uterus, and we have to see the contraction ring also that present as prolonged labor. The risk factor same as for abnormal uterine contractions ring, that is cannot be seen but can be felt per vaginal, can be present in any part of uterus, and can be seen in any stage of labor. Bandel's ring seen only in the second stage of labor. So, in first stage of labor, ring position are seen on internal os. Management we have to give by sedation. Second stage of labor, ring position seen at the fetal neck, hourglass, fetal neck. We have to correct it by general anesthesia or amyl nitrite inhalation. Third stage is hourglass constriction, that is retained placenta, and we have to manage by general anesthesia and manual removal of the placenta. So, Precipitate labor, that hyperactive and coordinated uterine contraction that leads to entire process of labor within 3 hours, most commonly seen in multiparous females, small size fetus, and previously history of precipitate labor. So complications in mother is PPH, laceration and tear, and inversion of uterus. In fetus is intracranial hemorrhage and asphyxia. Then how to manage to decrease the contraction? We have to give that general anesthesia and tocolytic, and episiotomy should be given.